Thank you, Brady. Good afternoon, everybody. As Brady pointed out, this is probably weird to have a PBM in front of you because I'll be honest, we hate PBMs too, so don't get mad at us. We think they're bad, but that's why we're here. But when we started the company several years ago, we were really passionate about saying most PBMs are basically built for the 80% of people in the middle. And 10% of people on either side, nobody seems to care about because there's not a good business practice. In their opinion, yep, we'll get into it. Yep. So at the end of the day, though, when we met Kevin and Brady, it was really, I'm a guy who grew up in, Fort Wayne, Indiana, suburban Indiana. I now live in Louisville, Kentucky. And my life experience tells me certain things. But my life experience hits a very narrow group of people. And so if we're really going to try to understand how we do things right for everybody, we need to live through a lot of different life experiences. And Megan has actually built something for us that doesn't exist in any other company out there. We think it's incredibly valuable and important, but it costs a lot of money. And that's why a lot of people don't probably want to do it. But at the end of the day, it's the right thing, and we think it makes good business sense too. So, part of as we go through our conversation here today, we will talk about what PBMs do and what they are, but we also just want to hinge on the fact that we feel there's a strong concept that good business is good business, and maybe we can also change the way businesses think about doing things so that hopefully we can give them different ideas on how they can expand their profits in ways that also positively impact their communities. So we'll hit a couple fronts here. But as we get into it, because the question came up, so what the heck is a PBM? And we talk a lot of acronyms, especially in healthcare, but pharmacy, it's even worse. So Megan, do you want to talk to us a little bit and explain what a PBM is and what they do?
Sure. So when you go to your provider, your prescriber's office, and they write you a prescription, you take that to a pharmacy or it gets sent to a pharmacy for you, right? The insurance that they bill is not your medical plan. It is administered, sometimes it's affiliated with the health plan, but a PBM is who processes that claim. So they manage the pharmacy network contracts. They're the ones who develop the formulary to determine if this medication is covered or is it not covered, or do you have to jump through certain hoops to get it covered. They're determining a lot of times the cost structure of what your copay is or how much your deductible or out-of-pocket max is dependent on your plan design. When you call the number on the back of your card to check to see how much a prescription is going to cost or what the coverage looks like, you're calling your pharmacy benefit manager. Does anybody know who their pharmacy benefit manager is, though? Yes, that is one. So a lot of times those things are happening in the background, though, and you just think, right, like it's my insurance, they're doing bad things. If you've had a lot of experience with them, then a lot of times you'll know the names, but it happens in the back end.
Thank you. And it's funny, right? Nobody really knows, or how many of you guys have even heard of a PBM before you came in here today? How many of you have a positive feeling towards PBMs in general? Yeah. And just for perspective, by 2030, so just in a couple years, the PBM industry is going to be a $1 trillion industry. $1 trillion. Think about that. So there's this industry that maybe people have kind of heard of. If you asked them what they do, they probably couldn't tell you. And it's a $1 trillion industry in the United States here in a few short years. So part of it is, one, PBMs don't want you to know about them because the things that they do benefit them and their shareholders and rarely benefit anybody else. You could call a PBM, in my opinion, an ATM, and that would be the same thing for the people who run them. Like, these things are literally printing tens of billions of dollars of profit a year. And that is all money that should probably be going to other things, in our opinion. So the first thing that we hope makes us different as a PBM is when we started, we came at it to say, here's what all those guys do that's wrong. Let's do something different that matters. And so first is, the corporate structure of a company really matters, right? Because it dictates the decisions that that company and the leaders of that company are going to make. So interestingly, when we started Affirmed about 5 years ago, I'm not one of those guys who runs around and starts up companies just for the hell of it. Like I'd never done it before. I didn't really know what I was doing. So, we went and found an attorney and said, hey, if we're going to start a company, what do you do? And he's like, so you go to Delaware, you become a C Corp. And he knew all along that we were trying to build something that was mission driven and not profit driven, but he still told us to go to Delaware. So we go to Delaware, we become a C Corp. About a year in, we're at one of our board meetings and we're talking about being mission driven and not profit driven. And same corporate attorney's like, hey guys, like time out. That's all sweet and wonderful, but I got to be clear with you that as a C Corp, you guys are all board members, and Greg, you're also an officer of the company. You have a legal and a fiduciary responsibility to maximize shareholder value. That's your job. So if you run around in public saying you're mission driven and not profit driven, that could put you, at odds with your investors and your shareholders. And we were like, well, cool. That's exactly what we were trying not to do, because that's the problem with healthcare, right? Healthcare companies' job is to make money for its shareholders. So when people continue to say healthcare is broken, it's actually not broken. It's working perfectly as designed. The problem is we have the wrong system. We should have a system where companies should try to work in the best interest of their client and the client's members, not a system that's working to make as much profit as possible through healthcare. So our reaction to that is we changed from a C Corp to what's called a public benefit corporation. So now as a public benefit corporation, we are still a for-profit company, but we have in our bylaws that we can never make more than a 3% profit. That's it. No more than 3%. So it won't ever put us at odds to negotiate against all of our clients to try to figure out how we make money off of them. We have philanthropic schedules built into our bylaws as well. So when we started the company, the foundation is you've got to do philanthropic things. You can't make so much money. But at the end of the day, we look at it, if we're doing business in what's going to be $1 trillion industry, and we're a couple percentage points of that, and we make a couple percentage points in profit, I think we're going to do okay. So let's not be greedy about this, and let's show that we can do things different. So then as we think about how other companies make decisions, Megan, the concept of PBMs and how they do business and their utilization management criteria, so not the team that you've built, but the rest of the industry, could you talk us through how it negatively impacts patients and members in a way that allows them to, well, basically forces them not to get their drugs sometimes?
Mm-hmm. Yep. So I think one of the first decision points is, as Greg mentioned, they're doing what is in the best interest of their shareholders, right? That's their duty, not what's in the best interest of patients or of members. So they design their formulary, or what drugs are covered, based off of what is going to make the most money, or that's part of the decision-making process. So when a claim processes, a lot of times the amount of money is associated with the cost of the drug. It's advantageous for them to choose a more expensive medication because they are going to make more money off of that medication. And in turn, then they force it to go to a pharmacy that they own, right? And so then they're choosing how much they pay themselves, and they're telling you where you can go to a pharmacy and where you cannot. So cutting out independent pharmacies locally, right? That's not in the best interest of our communities either. But then you get to the pharmacy counter at the one that they own, and the pharmacist says, hey, this drug isn't covered, or it requires a prior authorization. So then they're creating these hoops and barriers to where you're like, oh, well, what do I do now? What happens with this? Your provider, your doctor, has to fill out all of these forms, send it in, and they might approve it, but they might just come back and say, nope, too bad, you need to choose something else, right? So they're creating these hurdles, sometimes hoping that you just don't work through the process. And in turn, it just creates barriers to access to care. Utilization management is important, though, in certain cases, right? Like, we know that in healthcare, prior authorizations are needed before a service to make sure that or a product to make sure that that truly is what clinically is appropriate. It can be used for the good, but in the industry as a standard, it is not.
I have a question. Oh, just 1 second. Okay, this is a full-on trigger warning. What you're going to hear here is going to confirm a lot of what you heard about what goes on in the medical industry, and it's going to make you very mad if it hasn't already. So I'm not trying to be funny, but this is how it works. So thank you.
Yeah. Thanks, Brady. Yes, ma'am.
I have a question. I'm trying to understand why they are pushing the generic medicine on us and not the brand. And the reason I say this is because there was a blood pressure medicine I was on, and it's supposed to hit a diuretic and it's so forth and so on. But that medicine was actually causing me to have edema in my legs and my feet. And I'm telling my doctor, he was like, it's not supposed to do that. Okay, so let's go back and get this brand medicine. I take the brand medicine and it doesn't. Okay, so what happened is CVS said, okay, yeah, but if you want this brand medicine, your copay is going to be almost $300 per month. But I found out there are other little pharmaceuticals that you can get this same brand medicine from. So where I was going to pay almost $300 a month, I pay $50 a month. And it's worth it for my health, but I'm trying to understand why they keep pushing the brand medicine, and it is causing health issues.
Pushing the
Yeah.
generic.
Yeah,
Yep.
I'm sorry, pushing the generic, and it's causing health issues. And I think they know that it's causing all of this, because I talked to other pharmacies, smaller pharmacies, and they said they know.
Yeah. So I've got a little different perspective, but there's 2 points in there that are important. And again, so pharmacist by training. So I spent the first 20 years of my career working in community pharmacy. I think in general, generic drugs make the most sense because if we take a step back, the FDA says when a drug first comes to market is a brand drug, so a novel product that's never been introduced in the United States before, they review a drug to say, is this safe? Is it going to hurt people? And does it do what it says? If yes, they approve that drug and it has a patent on it, so they can be the only person to make it. After that patent expires, other companies can come in and make that drug. So basically, if you have a recipe for chocolate cake, and my wife has a recipe for chocolate cake, those recipes are going to be different, right? Because the things that you probably put in your cake are different than what she puts in hers. So what the FDA says is, no, there's only one way to make that, and you have to follow this exact system. You have to make it this exact same way with these exact same ingredients, and only if you make it that exact same way, and we taste both cakes and they taste the exact same, will we approve those drugs. So generic drugs are on the market for very good reasons, in our opinion, because they are forced to be made the exact same way, and if they're not approved. And we have competition then when generic companies, then you have 4 or 5 different companies making a drug, that's when costs come down. If we don't have generic drugs out there and there's only one company that can make that drug, they can price it whatever they want. And again, that's why we have $4.2 million drugs on the market today. One drug, one course of therapy, $4.2 million.
So explain to me why I was able to get it at a pharmacy.
That's the
like
second
in
part.
this area,
Yep.
but in Columbia, for $50 for one month instead of $300 for the same brand.
Yep.
drug.
So a drug price is never a drug price. Like every pharmacy in America you could go into and you could get the exact same drug and it's going to be a different price. And part of the reason goes back to what Megan said, right? So keep in mind, CVS is a PBM. They also own pharmacies, right? Now they also own their own supply chain. So they buy the drugs that they send to their CVS stores to sell to then have a PBM that approves said drugs, right? And their game is to maximize profits. We've actually seen through the state of Tennessee, I'll get you in a second, sir. Mark Cuban, he lists his drug prices. So Mark buys drugs and he puts his invoice online. So you can see exactly what he pays for drugs. He's the only person in America that does that. Everybody else, you have no idea what these drugs cost, right? Because it's all hidden. He marks it up 15%. So Mark's got this one drug. It's an oral cancer therapy, but it's been on the market for 20, 25 years. It's a generic. But the whole year, it's about $860. CVS, for the state of Tennessee employee health plan, would charge them $210,000 for that same drug. $210,000. Because nobody really knows what they should be paying, right? So that is very common, that what they do is they mark it up when it's in their store. And again, they try to force other pharmacies not to be able to fill it, so they drive their own profit that way, knowing that they're probably buying that same $300 drug for you that the independent's charging $50. The independent's probably paying more for that drug as well, right? Because they don't buy to the same extent CVS does. So to me, it's double bad. CVS probably bought it for $10, charged you $300. The independent probably bought it for $25, charged you $50. And is barely making enough to cover their costs and do all those other things. But they're trying to do things the right way, in my opinion. Does that help? Okay. Yes, sir.
Yeah, I was right along with what you're saying. I saw Representative Ocasio-Cortez interview the CEO of...
That was a great interview.
Yeah, and what she said was, what got me was, she goes, let me get this straight. She says, CVS owns Aetna, the insurer. And then she said CVS owns Oak Street Health, which is the clinic. Then she said CVS owns CVS Pharmacies, which is dispensing the medication. And CVS owns CVS Caremark, which is the PBM.
Yep.
So she says it's all one loop.
Yep.
How, is that what you're trying to disrupt? And if so, how?
That is exactly what we're trying to disrupt. Because, and it goes back, really, I mean, you could actually go back to 1999. So in 1999, an interesting thing happened. Have you guys heard of Merck? Yeah. Eli Lilly? Yeah. Yep. So Merck and Eli Lilly in the late 90s bought PBMs. So it was just a manufacturer that made brand name drugs, bought a PBM. Federal Trade Commission came in at that time and said, not allowed, right? Because to that formulary, so the PBM owns what drugs can be covered and what not. And they said, manufacturer, you're obviously going to prefer your drugs over a competitor's drugs. We are not going to allow a manufacturer to own a PBM. So just two entities together in 1999, FTC said no to. Fast forward to 2018. So in 2018, CVS, the parent organization, which owns CVS retail stores, CVS the PBM, Oak Street, they own Red Oak, which is the procurement, so they buy all the drugs. She didn't bring that up. They've also now started their own manufacturer. So if you want to have some real fun, look up a company called Cordavis. They're based in Ireland, manufacturing drugs for the U.S. market. Well, first off, why does it need to be in Ireland if you're only doing things for the American market? But so they own all these other companies. And so the FTC in 2018 said that's okay. So then Cigna bought Express Scripts, so now medical and pharmacies together, along with specialty pharmacies, dispensing, and all these other things. And the concept was that the FTC thought was okay in 2018 is that if you put all of these different entities in one vertical chain, it's going to improve efficiency, it's going to drive down cost, it's going to drive down, then what we all have to pay, and it's going to improve outcomes. Well, since 2018, does anybody feel their health care has improved? Okay, has anybody paying less for health care in the last 8 years? And it's doubled. So that is our contention, and what we're trying to disrupt is to say, first off, a PBM should never own a pharmacy. Because I will never own a pharmacy, because when I, as a PBM, get to send drugs to my own pharmacy and decide what I pay myself, bad things happen. Bless you. So we think vertical integration is bad. We need to start breaking these guys up and show that let's have companies working next to each other, doing what they're the best in the world at, only focus on one unconflicted thing. That's where healthcare starts getting better. Yes, ma'am.
So I just wanted to clarify, so currently there are drugs that you cannot get at certain pharmacies? Is that because of this system? Is that what you're saying?
When you say you can't get them at certain pharmacies, or is there a particular drug, as an example, like that
We don't cover Novo, right? Insulin, we just cover Lilly.
Well, I'm thinking if it's at a particular pharmacy and not just in general, it could be something like a limited distribution drug where only like a specialty pharmacy where for specialty products, a lot of times PBMs will require you to go to a specialty pharmacy. But then if there are specific counseling or there are requirements for specialty drugs that are indicated by the FDA, if you have to inject yourself, the manufacturers have contracts with one pharmacy or two pharmacies in the entire United States. So then you would have to go to that pharmacy for that particular drug. In general, most drugs should be available at all pharmacies.
Yes, sir. I got a situation. My fiance, just back to, but anyway, the drug is vanity.
Uh-huh.
We moved from covered, from CVS to covered. The whole Trump box. And so they told her, we're no longer going to a service, you gotta go back to CVS. Go back to CVS. Then move all her medication over except for Xanadine. Xanadine is only covered in Fidelity. You only get covered. It's now $300 to $400. 300 to 400. So we're fighting with the insurance agency why we can't get this shit. Now, many people we get it over here at CVS, and the insurance covers CVS, but won't cover us.
Yeah. Well, and I'll get you in a second, Carrie. So basically, the statement was right. They're pushing them around. We had to go from here to here, and then back to this other pharmacy to get our stuff covered, and then only certain drugs are still covered at certain pharmacies. So, and that, which Megan will talk about next, is why we think patient advocacy and communities really start to matter, and some things that we've done different that we hope others will start to do, because it's really hard to, for you personally, to have to then try to figure all this craziness out, right? And I always joke, Megan said it a little bit earlier, but you know, I phrase it differently, that, you know, I think the PBM's mantra is in chaos there is profit. And the more chaos they create, the more profit they create for themselves. So they like this just totally messed up system because it's just hard for people to do certain things that are unprofitable for them. Carrie?
Yeah, so it does seem like there's a lot of prescriptions and things that are going to like compounding pharmacies and like I think it's like the Ozempic and those types of drugs. I'm thinking a compounded pharmacy drug, but it seems like are they pushing to go that way, or is it just specific drugs? Because it seems like that's throwing in a whole nother wrench into like if you're going with PBMs now, like what's going to eventually happen? Everybody's just going to be compounding their own drugs, and I've got several medications that I can't even get, right? So how is that? I mean, it may not totally be in your realm, but is that something that's being dealt with the PBMs? Is access to drugs, things, you know, including these compounded drugs that, of course, insurance is like, oh, we're not covering it, but your doctor's like, you need this. So.
Then do you want to end with PCAs?
The compounded products is an interesting dynamic in which I think the compounded route has been an avenue for access where it isn't available in another way and a more affordable option, right? So we can get the brand name medication prescribed to us, but our insurance isn't going to cover it because it is cosmetic of some sort and what they deem, right? Or it's not something that they're required to cover by the Affordable Care Act.
You're a female,
Yeah.
and those medications aren't covered?
They,
I'm just,
yeah, they're not covered. Yes, those are things that we face. The compounding world has not taken advantage of that, but they've found a path to affordable care or a more affordable option for members, and it has exploded. I think as we continue to push and drive for additional coverage and affordable medications, maybe that will shift some.
Normally when we go to our doctor, because normally we like trusting our doctor,
Mm-hmm.
and this might not be the best
Right. So there are tools and resources that should be available, and we could have independent conversation, right? Like your PBM might have an app, or you could utilize even like Mark Cuban Cost Plus Drugs app, or GoodRx is another example that can provide the approximate cost to you to be able to say, like, your doctor's going to say, okay, I'm going to prescribe Advair Discus for your asthma. You can search that to see if there are other products within the same class of drugs, meaning it's going to work, or it should work as well, maybe even better, depending on exactly what's wrong, at a lower cost to you. Or you can see coverage within that as well. But that question in and of itself is patients don't always know how to advocate for themselves, right? And we recognized that with the PBM industry and the world that we live in, with as complicated as healthcare is. So when started Affirmed RX, Greg started Affirmed RX almost 5 years ago, we created a role to actually combat that and provide advocacy efforts for our members and patients to kind of work alongside of them. So we have a team of patient care advocates, and that is their one and only job. So they're watching claims process in real time, right? The doctor has sent the prescription to the pharmacy. You haven't even gone to the pharmacy yet. You're still at the doctor's office, and they can see that claim rejection. They can see that the claim has rejected at the pharmacy. So they can pick up the phone and they can call your doctor's office to say, hey, this isn't preferred on the formulary. Here's what is. But if this is truly what is clinically appropriate, here's what you're going to do. Here's how you're going to do it. And here's the information that I need. And then they're going to pick up the phone and they're going to call you to say, don't go to the pharmacy just yet. Here's what's happening. Here's why it's happening. And here are some cost savings opportunities, like a manufacturer cost support card. Let's get you enrolled in that. And then walking you through every step of the way to make sure that you're informed and you understand, and that things continue to move throughout that process.
Sorry, 1 second. I owe him one real quick. Yes, sir.
Really a quick question.
Yes.
So one of the arguments I think that PBMs quite often use is that the accessibility, the availability of your corner Walgreens, your corner CVS, that you can get your medications there, and the economies of scale that they have. And they quite often cite like rural areas, right? Rural populations that say you would have to drive longer if you didn't have this Walgreens or the CVS. Is that true? I mean, it doesn't seem like it's. I feel like that's kind of their go-to answer, is that the availability of their, kind of regime, is what is because people like healthcare access to medications is such a personal thing, right? You
Yep.
don't have your drugs. It's serious. If you have to go further out to get your drugs, it's really serious. Like you drive an hour or 45 minutes to some areas. But that seems to be the kind of story that they say, like, get rid of us and you have longer drives. And I think in Arkansas there's a bill right now in the state legislature about regulating PBMs in Arkansas, and that's their go-to answer. It's like, if you want people to drive an hour to go get their medications, then get rid of us. Otherwise, we're going to do it.
Am I allowed to say bullshit or no? Sorry. Sorry, Brady. I thought I'd just give the short answer and then elaborate. It's all framing, and it's poor framing in my opinion. Because let's be honest, 4 years ago CVS had 12,000 stores. Now they have under 9,000. Walgreens had 11 or 12,000 stores. Now they have under 8,000. Rite Aid's out of business. They're just gone. All their stores are gone. Community pharmacies continue to close. So one, I contend nobody really cares about community pharmacy unless you own one from a PBM standpoint. Then you care about yours, but you don't care about anybody else's. And frankly, if everybody else goes out of business, that just drives business to yours. So that's false. Two, especially with mail order, and I'm not saying mail order is the right answer, but mail order can get to everybody in America. So, and I also contend You know, yes, we talk about rural America, but let's talk about urban America too, because all of those pharmacies that are closing in urban America. Very few are actually closing in rural places. They are some, but more of them are in low income, already underserved communities. So yeah, they could say, hey, there's still a pharmacy 7 miles away from them. Get to it. It's still not easy. So again, I think we're framing the wrong conversation here. And we really should talk about, again, how people who live where they want to live and the communities they've probably lived in for generations are going to get care. And it doesn't matter who's there. We need to have a well-functioning community pharmacy system that helps everybody where they are. And we're not there, and we're actually getting further away from it every day. Yep. Give me a second. Yes, ma'am.
Yeah, so given what you shared that your shareholders
Thank you. That is the best question I think I've ever gotten. And hopefully we can help answer that. But I think the short point, and Megan, I'll be interested to hear your comments too. I always go back to, I lead with those same two questions. One, when was the last time you thought your healthcare got better? Right? Like for years, our healthcare is getting worse. And by the way, when was the last time your costs went down? You know, everybody laughs. They're like, oh, healthcare costs never go down. Okay, so let's take a step back for a second. Who owns the rules of this system? It is the guys who are running the system. CVS has been running the system. United Health Group has been running the system. Cigna has been running the system. So one, their profits continue to double. They're making, again, tens of billions a year in profits. And our healthcare is getting worse and our costs are going up. What is the definition of insanity? That is the moment in time we're in, right? Everybody's like, well, we need United Healthcare, and say, why? Why? Megan's team does a significantly better job than anything that those guys would ever consider doing. All day, every day. I mean, we've got the same network access they do. We've got a better formulary than they do. You know, there's plenty of companies out there that will do it right and do it in a way where it aligns the interest of the company with that of the communities it serves. Why don't we look for something different? That, to me, that is the easiest way to explain it, is they've controlled the system and this is where they've gotten us. Do we want more of that or not? Because if you keep using them, that's what you're going to get. In a second, what would you say, Megan?
To answer the part of the question of what should we do, right? I would continue to encourage you and the people that surround you and your communities to advocate for themselves or to push. Ask the questions of why. Why is this who we chose, right? If with your employer group, if you have benefits through your employer group, ask the hard questions to your benefits team because they're the ones making those decisions. And ultimately, they have the financial responsibility to make the right decisions. So if you're asking the hard questions, you're doing what's in the best interest of you and your community.
She actually kind of hit on it. I was just like, what do we do in our communities to fight back? Because, there's like, oh, just order it from us online. Every time you sign into my insurance, you're like, you got to order from us. It'll be better. It'll be this. It'll be that. You can get your drugs on time. So how do we fight back against that huge engine of, this is what you're dealt with. You just have to deal with it.
Yeah, it's a status quo issue to me, right? We can continue to accept the status quo and we're going to get it. But again, there's enough examples out there. And again, like our clients are 7-Eleven. Purdue University, very sophisticated university. We do a great job for those guys. So there's enough reasons, and there's other competitors of ours that do a good job too. Like, you can continue using CVS, Optum, or Express Scripts, and you're going to get what you get, or you can make a decision and do something different. That's what people need to start trying to figure out. Like, it's in your hands, right? The people who make the decisions, those benefit people, it's in their hands. And they choose to make the wrong decision because it's the easy one, right? Like, the PBM industry, we joke, it's, the old saying, nobody gets fired for hiring IBM back in the day. Yeah, IBM was more expensive, but they were like the easy button. Well, you get the easy button, you're going to get increased costs and lower outcomes. Yes, ma'am.
Is this like an antitrust issue then, with the fact that they control so much of the supply chain?
We didn't just talk to the Department of Justice recently about that. No.
I think that AOC that was part of her conversation, right, with the antitrust, like.
Yeah. No, it severe. And it's interesting, like, less the big guys, but the blues plans, they're just as bad.
They are.
So, and again, they just come to us and they say, no, we do the medical, and the pharmacy and the medical have to talk. And they just won't even talk to us. So then they just carve groups like us out, and we can't even do business with any of their, 110 million members because it's just not advantageous for them. So why would they do it? So, yeah. Yes.
So, A, thanks for coming out. This is really interesting. Black maternal mortality. So we run blackwomanomics.com, which is a website that's focused on the issue. Kevin knows, we've been very critical of the current mayor, black woman in D.C., city with the highest rate of black maternal mortality. Wondering what you're doing in that area and if there's a way to take the kinds of patient care advocacy skills that you have and apply it to a single, silo.
I'll answer the first part. You can maybe answer what we can do in a silo piece because your answer is hopefully going to be better than mine. I'm not doing anything yet, right? But that's also why we work with Kevin and Brady. Because we want to figure out these areas. Like, we've got a roadmap on things we need to do better. I still have to build a better formulary, right? I need to understand in all the communities, there's certain medications that matter to certain groups of people differently, and are we covering those drugs at the right copay? I'm probably not doing that to the extent I should be today. When we approve our formulary, are we looking at community impact of the drugs that we're approving and taking that into account for formulary approvals? I'm not. Nobody is. But, we're trying to do better and we lead. So these conversations are important to us to make sure those things we're not thinking about, we start thinking about. Because our goal at the end of the day is to take care of 100% of people. Again, not just the 80 in the middle. So that's a great question, and it's something we need to do better on ourselves. Megan?
To reflect on. To reflect on what Greg just said, we're not doing everything that we can, or right? Like, the opportunities here are endless. I think we're making steps in the right direction. Our patient care advocates have a broad range of experiences. We have some nurses, some social workers, some pharmacists. We are working to get as many as we can trained as community health workers within their particular area so that they can identify some of those social determinants of health or opportunities for them to advocate for those patients that go beyond a prescription that's attempting to process, right? How do we know what is happening within that member's life that we can help support without a claim processing? And there are tools, this might be a good segue for AI too. But there are things that we can pull in. It's just figuring out the how to. How do we get involved? How do we help? How do we support? It can happen depending on your coverage. If I was asking an individual and actually trying to figure out how to navigate that and it's outside of Affirmed RX, there could be a set of questions that could be posed to the PBM or to the employer group. So this is going to get into the detail like weeds, but if you work for a company that has more than 200 employees, chances are they're what we call self-funded, meaning they make the decisions of the plan, whether they realize it or not. So they made the decision, are compounds covered or are they not? So if you truly need something covered, reaching out to your benefits leader is always an option if you fall into that category. Or you could even just ask the question of, are we self-funded or are we fully funded? There's oftentimes verbiage on your insurance card that tells you that as well. But then the next step is, okay, if compounds are covered, what makes that covered? Do all of the ingredients have to be on the formulary? Maybe the pharmacy's just submitting with a product that's not, and that can be adjusted within the formulation. So trying to get creative in that way. I would love to say that there's a path to coverage with every PBM and every benefit, but there may not be, dependent on how that benefit is structured.
Awesome. Thank you, Megan. And I know we're up on time, but I will end with one thing real quick. Back to your question. The other thing you can do if you need help in your communities having these conversations, you know Greg and you know Megan now. Keevan and Brady definitely know how to get a hold of us. Let us know how we can help. We've testified to Congress numerous times on this topic. I come to Washington, D.C. all the time so that we can help policymakers and rule makers understand what's happening in this industry, and we can continue to hopefully put it in a better spot. I don't think federal policy is where this ends. I don't think it fixes it because these guys are so big and they're so complex that they're going to work their way around it. But we do look at it as the more people are talking about it, the less hidden they are, and the more we know about how bad they are, hopefully the more pressure we can put on them to make it better. So these are important conversations. And again, if we can help you with these conversations in your community, give us a call. We'd love to help. So thank you, guys.